Welcome to my video. Just to let you know, I have no financial interest. To get new educational videos and updates, please subscribe to my channel. I'd be very grateful if you could please like and share this video, which I hope will give you a beneficial knowledge. Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullah. Hello, we're going to discuss today how to manage a very important disease, which is the diabetic macular edema in NHS National Health Services in England 2020. Why we choose this topic to start with? Because it is the commonest cause of drop of vision in diabetic patients. It is a very common case in our day-to-day practice, and it is very common question to be asked in exams, especially FRC opth exam, and you will be asked in the FRC opth exam about any of the topics that we are going to discuss today, either in the MCQ or written or Viva or OSCE. Treatment options has to be individualized to every patient because we have different modalities, and this framework that we are going to discuss today will give you some kind of how to fit every treatment option to be suitable for every patient. We know about the relation between the pathology and the vision, and in diabetic macular edema it is not very well correlated. So we can see people that have very good vision and have a lot of diabetic macular edema, and we can see the opposite. So after the treatment as well, some patients have very good response with poor vision, and some others have poor response to treatment with good vision. So it is a little bit not very related to the pathology, and we cannot. So this is still under investigations and studies. The other thing that it is not an emergency, so you have time to manage, and we can see this during the COVID-19 pandemic, that most of the patients didn't get much worse after this period of lockdown. So you have time for the patient to decide which treatment option they like, and you have time to act. So the other thing is the treatment modalities now are very different, and they are changing every day. So we are going to discuss the latest randomized controlled trials and evidence for this disease. So we will start with what factors affecting the choice of our treatment options. We have factors in the patient and factors in the eye. So as regarding the factors of the patient, the most important thing is the HbA1c level for the blood sugar and the diabetic control. So according to the recent randomized controlled trials, the DCCT and the UK PDS trials and ACCORD trial, we found that controlling the diabetes will help reducing the diabetic retinopathy and will improve the diabetic macular edema as well. So this is a very important factor in the treatment, to know if the patient is poorly controlled or well controlled, and this will help which options we can decide. And the other thing is controlling the blood pressure as well, because the blood pressure is very important factor in the worsening of the diabetic macular edema. The blood cholesterol has to be controlled, and the renal condition has to be assessed as well, because we can see that in some patients, when the renal functions are poor, the diabetic macular edema start to get worse quickly. The other things like smoking, obesity, this has to be controlled as well. When we can see some of the patients that are stopping smoking and controlling their diet have improvement in the diabetic macular edema. We have to assess if the patient had recent cardiovascular events like myocardial infarction or heart attack or stroke. This will change the modality of the treatment. Learning difficulties as well will change the modality of treatment. Either the patient can sit on the slit lamp doing laser or not. This will be one of the factors that will decide our treatment options. The pregnancy is one of the very common risk factors that are making the diabetic macular edema worse. So we have to make sure the patient is not pregnant, and there are some treatment modalities that are not studied with the pregnancy, and we have to avoid that as well, not to make any problems with the baby. So in the eye, we have to decide at which stage of the diabetic retinopathy the patient is. Is it proliferative or non-proliferative? With the proliferative, we can use some treatment modalities that can help controlling the proliferative disease as well. And the location of the edema is very important. The thickness, which is the central subfield thickness on the OCT, is very important. And the vitreomacular traction. So three factors in the retina: the diabetic retinopathy state, the location of the edema, either central or non-central, and the thickness. The vitreomacular traction as well is important factor in deciding which modality we will choose. If the patient had previous vitrectomy, this will make some changes as well, because previous vitrectomy can make some of the medication that we are using intravitreally to be short half-life, so the efficiency of the treatment will be less with time. And the lens status, the inflammation in the eye in general. If it is active inflammation, we cannot use some of our medications. If there is any infections in the eye, either in the anterior segment or the posterior segments, if there is glaucoma which is not controlled or controlled, we have to decide which treatment options, because the intravitreal injections and the intravitreal implants, most of them will make the glaucoma worse. So we have to make sure the intraocular pressure is measured before starting any treatment, and we have to exclude glaucoma. And if it is advanced and uncontrolled, we have to choose other treatment modalities. The last thing is if the patient is known to be steroid responder or not. So the most important three factors are the location of the edema, the thickness, and the lens status. So the most important factor in controlling this diabetic macular edema is to control the risk factors, which is the diabetes, the blood pressure, the high cholesterol, and the renal status, the smoking. The patient has to stop smoking, and the diet, the patient has to control his diet as well, and to avoid stress as well. So these are the most important thing in the treatment. And I'm stressing on that because some of the patients are coming for intravitreal injections, and at the time they are scheduled for the injection, we found the edema has gone, and we were asking the patients what happened. They said just we controlled the diabetes and the general factors well. So this is very important thing in the treatment. The second thing, we have to be oriented of the location of the edema. So to decide the location, it is easier to use the OCT machine, and most of the OCT machines now have this OCT map. This map is having one circle which is 1 millimeter diameter, and the second circle is 3 millimeters in diameter, and the third circle is 6 millimeter in diameter. This is according to the ETDRS study, or the early treatment diabetic retinopathy study. So the radius of this circle is 500 microns, and the radius of the bigger circle is about 1500 microns, which is nearly about the disc diameter. So why we are saying that? Because if the edema is not within the second circle, which is 3 millimeters from the center of the fovea, so there is no need to treat. You just control the risk factors. We'll go on this further after the next slide, but in general you have to be oriented with this circles, because this is a very important factor in deciding the treatment. And you have as well here the thickness, the retinal thickness, with this colored map, so you can know if there is any thickening in certain areas and how much is this thickening as well. So first, the flow chart. We are going to summarize now the treatment modalities according to certain factors that we have discussed in the eye itself. So first, the vitreomacular traction. If there is a vitreomacular traction with the diabetic macular edema, it is better to refer to the VR consultation. So you can do vitrectomy together with pharmacological treatment or not, but it is a VR case for removing this traction. If there is no vitreomacular traction, so we have to decide, then we have to ask ourselves, is it central or non-central? So central, there is no certain definition, but the approved definition in UK is about the central 1 millimeters circle of the ETDRS on the OCT machines. So if the patient has central edema, or the other definition is just less than 500 microns from the foveal avascular zone on the FFA. So if it is central, there is some other questions we are going to ask. If it is non-central, which is more than 500 microns of the foveal avascular zone, or outside this central circle, which is 1 millimeter. So if it is non-central, we have to ask, is it clinically significant or not clinically significant? So if it is clinically significant, according to the ETDRS study, there is definition for that, and it is a very common question in exams. So if it is clinically significant, there is 3 criteria. The first one, retinal thickening within 500 microns from the center of the fovea, or heart exudates adjacent to retinal thickening within 500 microns of the center of the fovea, or area of retinal thickening disc diameter within one disc diameter from the center of the fovea. So you have to know this definition very well, because this will be asked in any exam, because this is the criteria that are going to be followed up in the treatment. So if you have a clinically significant macular edema, it is better to treat with laser, because according to the ATDRS study, this shows that there is reduction in 50% of the patients of moderate visual loss. So there is a great benefit for the patient from the treatment. So when we weigh the risks and benefits of the laser, so we have to tell the patient about this study, and this is very important in deciding which patient to treat. If the edema is not central and not clinically significant, so there is no need to do anything except controlling the general risk factors. By the way, it is clinically significant macular edema, so according to the original definition, we are not using the OCT to decide this, but now the OCT is helping us to decide it, so it is better to use the OCT in deciding this, because it is very difficult to have an objective definition while examining the patient clinically on the slit lamp. If it is clinically significant macular edema, we can use OCTA now or fluorescein fundus angiography to exclude any ischemia, but we can do the focal or the diffuse laser according if it is focal or diffuse edema, and you can use the argon laser or double frequency egg or any kind of machine. And now there is a new advances in the laser treatment by using subliminal or micropulse or sub-threshold laser, which all are the same, but it's just using the power which is less than the usual power of the laser to activate the RPE without doing damage to it. And it is better for this subliminal or micropulse laser to be used if the thickness is less than 400 microns in this area. So as we said, we can use OCTA or FFA. It is not mandatory, but it can guide you about the foveal avascular zone and the ischemic areas to avoid this while doing the laser. If it is not clinically significant macular edema, as we said, we just observe the patient in about 6 months, and we can do some virtual clinics or digital surveillance clinics. So this will be involving doing just photography for the patient, and then we revise the OCT scans and see if there is any worsening or not. So this criteria for the virtual clinics or the screening clinics, we can use it for the patient that have R1M1, and this R1M1 is just staging of the diabetic retinopathy in UK according to the national screening program here. So if it is central, as we discussed before, we have to ask ourselves what is the thickness. So if the thickness is more than 400 microns, we are having some treatment modalities. If it is less than 400 microns, we have other modalities. So why 400 microns? This is according to the NICE guidelines, which is the National Institute of Health and Care Excellence in UK. So we find that according to the randomized controlled studies, the RESTORE, the RESOLVE, and DRCR-NET, Protocol I, and READ studies, they found that the most effective reduction in the thickness and the best gain of the vision is at this thickness. So they put this as a cutoff in the treatment with the anti-vascular endothelial growth factor treatment like ranibizumab or aflibercept, and this is the mainstay of the treatment at the present time. So if the thickness is more than 400 microns and the patient, so you have to ask if the patient is phakic or pseudophakic. If the patient is phakic, and you have to ask as well a question if the patient has a proliferative diabetic retinopathy or not, because this will go with the anti-vascular endothelial growth factor intravitreal injections. So if the patient is phakic and has some proliferative disease, it is better to use the anti-VEGF, the aflibercept or ranibizumab. And these two medications are the licensed medications in UK, and we try these medications for about 6 months. It varies according to the studies, either 3 injections or 6 injections, but in my opinion it is better to wait 6 months to see if it is effective or not. So if the patient is responding, which means that there is decrease in the central subfield thickness on the OCT more than 20% and the vision is improving, so it is better to treat and extend, and you can extend in these cases by 1 month. And if the edema is resolving and it is not central, we can give some rescue focal laser treatment as well. If the patient is not responding, which means that there is decrease in the central subfield thickness less than 10%, or the vision is not improving, less than 5 letters gain, so we can switch between the medications. And if the patient is having mobility problems, or if the clinic is very busy and the patient is not compliant with the treatment, not coming in the arranged appointments, so we have to think about other treatment options. And if the patient is pregnant, because the anti-VEGF is not studied during the pregnancy, so in general we try to avoid this, especially in the first trimester and the second trimester, but we can see that some patients are pregnant and they have the treatment as well, but it is better to avoid pregnancy, and you have to inform the patient to avoid pregnancy after 6 months from stopping the treatment as well. If the patient had heart attack or had stroke, so it is better to avoid the anti-VEGF, because there is a theoretical risk of making this worse. There is a debate about that, but it is better to avoid, especially in the last 3 months. If the patient had cardiovascular event, it's better to avoid the anti-VEGF injections. Or if the patient have active inflammation, or if the patient is vitrectomized. The vitrectomized patients are not strict contraindication, but the half-life of the medication is getting very short, so it is better to use other modalities. So if the patient is pseudophakic and the thickness is more than 400 microns, in UK we go more with the corticosteroids. You can use the anti-VEGF as well, but it is better to go with corticosteroids. and the most common approved medication is doing a dexamethasone 700 micrograms intravitreal implant, and it lasts about 3 to 4 months, so it gives more time. And during the COVID-19 pandemic as well, it is better if the patient cannot come frequently, so this will be safer treatment. And if the edema become chronic and it is not responding to any of the previous modalities, we can, and the patient is pseudophakic, we can use the fluocinolone acetinoid implant as well. But this is if the edema become chronic and not responding to previous treatment. There is two other options which is not licensed, but you can use it if it is indicated. So you can use the triamcinolone acetinoid intravitreal injections, or the posterior subtenos triamcinolone injection if the intravitreal steroids are contraindicated. So what is the contraindications of the corticosteroids intravitreal implants? The first thing is loss of the intact posterior capsule, because if these implants come in the anterior chamber, it is very toxic to the endothelium and it might make endothelial decompensation in very short time. So please try to examine the patient very thoroughly before any implant that you're going to use. So the first contraindication is if the patient is aphakic, or putting in iris clip lens because of the aphakia, or there is peripheral iridectomy that make continuation between the anterior chamber and posterior chamber, you have to avoid. There was a good question about if the patient have YAG laser posterior capsulotomy. It depends according to the opening of the YAG laser capsulotomy, and if there is any posterior capsule rupture that happened in the during the cataract surgery. So it is better to assess the patient well, but you can use it if the patient is doing YAG posterior capsulotomy, as long as the optic is covering the capsular opening. The other things that are contraindicated if the patient had previous infections like herpes infection or toxoplasmosis. So this is a contraindication of using this steroid implants. If the patient have uncontrolled and advanced glaucoma, it is better to avoid it, except in very rare cases that there is no other modality can be used, and if it is under direct continuous monitoring of a glaucoma consultant controlling the intraocular pressure while putting this implant. So if the patient is having problems with the steroids previously, like rise of the intraocular pressure, which we call it steroid responders, so you have to avoid using corticosteroid implants. And by the way, the rise of the intraocular pressure after the this implants is mostly not very severe, and in most of the people it is managed by medical topical treatment, and very rarely you might need to do glaucoma operations. So it is better to warn the patient about the rise of the intraocular pressure, which happens in about 30 to 40% of the people. So if the steroids cannot be used, you have to tightly control the diabetes and observe the patient and see how things are going. We can use bevacizumab, but it is not licensed, and you can use it in trials or studies, but it is not a licensed option. So if the central subfield thickness is less than 400 microns, either the patient is phakic or pseudophakic. So you have to ask yourself if the patient is phakic or pseudophakic. So if the patient is phakic, there is no much we can do. You have to observe the patient and try to control the diabetes with the other risk factors. You can use the bevacizumab, but this is not licensed in UK for this treatment. So if the patient is pseudophakic and the thickness is less than 400 microns, you can use the corticosteroids implants like the dexamethasone implant. And if the edema is chronic and not responding, you can use the fluocinolone acetinoid 190 micron implant. And the OCT findings, the hyperreflective foci that are representing the microglia and the subretinal fluid is responding better with the steroids. So this things that you can put in mind while seeing the OCT scan. So to sum up this summary, you have to ask yourself first, is it a vitreomacular traction? So you refer to VR for consultation and management. If no vitreomacular traction, so you have to ask yourself, where is the edema? Is it central or non-central? If it is non-central, so if it is clinically significant macular edema, you have to do focal or diffuse laser. If not clinically significant macular edema, so you can observe and do virtual surveillance. If the edema is central within the 1 millimeter circle of the ETDRS, so you have to ask yourself, is it more than 400 microns? And if it is more than 400 microns, if the patient is phakic or pseudophakic, so you can use the anti-VEGF injections. If the patient is responding, so you can do treat and extend and focal laser treatment as a rescue. If not responding, so you can switch between the medications. And if the patient has cardiovascular events or pregnant or active inflammation or vitrectomized, or if the patient cannot come on frequent visits and not compliant, you can use the corticosteroids. If the corticosteroids are not indicated, so you can observe and tightly control the risk factors. If the central subfield thickness is less than 400 microns, so you have to check if the patient is pseudophakic, so you can use the steroids. If phakic, so you just observe and control the general risk factors. So I hope this summary flow chart is going to help you to manage your patients better. And as I said, it is just the flow chart in UK according to our evidence and according to the recent randomized controlled studies. So I'm putting the links for all the evidence based studies that have been done in the comments under this video. And I hope that this very quick summary is helping you with your patients and helping you with your exams as well. So you have in summary, you have to ask yourself, first, the vitreomacular traction, second, the location of the edema, and if it is not central, is it clinically significant or not, and if it is central, what is the thickness? If the thickness is more than 400 microns, we usually use anti-VEGF as the first line of treatment. If there is contraindication to anti-VEGF or other factors, or the patient is not responding, so you can use the corticosteroids, but the patient has to be pseudophakic according to the license here in UK. And if the thickness is less than 400 microns, so you have to decide if the patient is phakic or pseudophakic. If pseudophakic, you can use the corticosteroids. If phakic, you cannot use the corticosteroids and you have to observe. So now it is your turn. Are you ready? Are you ready for the prizes? Okay, so after every presentation of the important topics, we're going to do a quiz. And the first one to get this quiz right will have a prize after each month. So watch for the prizes on the channel. So the first question today is, all of the following are true about definition of the clinically significant macular edema according to the ATDRS study, except. So number one, retinal thickening within 500 microns of the macular center. Number two, hard exudates within 500 microns of the macular center with adjacent retinal thickening. Number three, hard exudates within one disc diameter of the macular center. Number four, one or more disc diameters of the retinal thickening, part of which is within one disc diameter of the macular center. So just type the answers under the video comments, and the first one to get it right will get a prize after the first month. I'm happy to receive any questions or comments in the video comment on my YouTube channel, and thank you for watching, and watch for the next important topics summary. Please subscribe to have all the updates, and if you feel that it is beneficial, just like and share. Thank you for watching.